Okay, so the YouTube has started, so I'll share the link in the chats here. Okay. Kritika, can you share, check the YouTube live feed, please?
Yes, ma'am. It's not yet started. I'll just keep you updated.
Ma'am, I think now
Kritika, yeah. I think one of the devices, I think you have to put it on mute.
Oh, sorry.
So I think it's mine also. Let me. Okay. So Kritika, YouTube is still on, but no double voice now, isn't it?
Yes, ma'am. No double voice.
Okay. If there's any problem on YouTube, let me know.
Yes, ma'am.
Okay. So we are all set with the live stream. Apurva, you can start. People will join.
Yes, ma'am. So I welcome all the participants to this program. We are doing it in collaboration with the Down Syndrome Foundation of India. Dr. Surekha, Dr. Brinda, thank you so much for organizing this and collaborating it with us. I welcome everyone. I hope we have a fulfilling session and with a lot of learning and with a lot of joy.
Oh.
Thank you, Dr. Apurva, for this opportunity. On behalf of the Down Syndrome Federation of India, we would like to thank Brainchild Trust and Dr. Ravi Kumar for taking this initiative. Thank you, Dr. Gauri and Dr. Apurva for coordinating with us on this event. We look forward to a 1.5 hour of fantastic information. So without much ado, I think we should begin. We will begin with Dr. Gauri, who would start with the medical aspects of Down syndrome, and then we will move on to our therapists. So we'll start with you, Dr. Gauri. Thank you.
Yes, thank you. Let me share my screen. I think it's all visible, isn't it?
Yes.
Yes. Oh, okay. Hello, everybody, and good evening, and thank you for joining us here for this session. And thank you to the Downs Federation team also for collaborating with us here. So without any delays, let's move on to the brief bit of the medical part of the Down syndrome. As you all know, it is mainly an extra chromosome that is there at the 21st gene allele. It is very common. So we see this quite a lot around us. And let us look into a little bit more about where exactly the problem is. So if you look here at the 21st chromosome, so all of us have 23 chromosomes. At the 21st, instead of 2, there is actually 3 chromosomes there. If it is present in all the cells of the body, it is the most commonest one, which is called trisomy 21. Or if it is only present in a few cells of the body, it is called a mosaic pattern. And if this extra chromosome is present on any of these other chromosomes, then it is called a translocation. And there is a lot more in depth when we look at these genetic results, mapping, there's a lot more going on. So as a therapist, when you are seeing parents of children with Downs, if they ask you, will my next child also have this Down syndrome? It is a very difficult answer. But the good thing over here is around 96% of these translocations or whatever is happening here in genes is just isolated. Yes, there are a few risk factors that put a mother who's conceiving at a higher risk for having a Down syndrome baby, but not just having a Down syndrome baby puts you at a higher risk. So it is complicated, and if they want more clarity as to what is happening, what is the basis and the risk in future pregnancy, I think it is very apt for them to come and see a genetic counselor wherever they are available. And so what are the, okay. What are the problems that you oversee in Downs? So whatever with the development part, milestones and everything, I will leave it to the Downs Federation. With the health problems also, it can affect a lot of various other organs. These children or parents may not be seeing a regular professional like a doctor, pediatrician on a regular basis. So when you are picking up, when you're seeing them in your clinics in a day-to-day basis, if you feel something is not right, therapy has been going well, something has changed. So these health problems could be the reason why there has been a hindrance or a problem during your therapy, or something that may be hindering their development. So it is very good to have a view of overall view about what problems could happen. So the main key is you identify this early, you will be able to manage them better, and you'll be able to support them better as well. As we all emphasize on early identification, early intervention, early treatment, we're getting better end goals. I think we need to be all aware and look out for them when there is some problem in your ongoing therapies. Thyroid problems is a very high common occurrence. So 16 to 20%. Generally, at birth, they need to be tested 6 months and then yearly. And this thyroid issues can cause problem with their attention. Already, they may be overweight. It may be causing on to more of weight issues as well. So then it can go on to hamper the physiotherapy or speech, the tone, everything it can affect. So this is a thing that needs to be monitored regularly. Heart conditions is also very high, but this generally when a pediatrician is looking at them, they will deal with it. Growth, again, we all know that they have their own separate growth charts. So that needs to be monitored. And again, the difference in their growth itself can cause obesity. Again, the low tone and the less motor activity due to this can also lead to obesity, and that can again in turn cause a vicious cycle on their growth and development. Intellectual disability. Again, we need to keep in mind that each child is different, whatever their condition is. So it could be mild to moderate. So we need to have a regular assessment to see what is going on, where they need support, and what is going okay, what is not going okay, and support them in the respective fields. So respiratory infections. Again, the main thing when you look at a Down syndrome child, so again, the difference in the face, the hypoplasia, that is what is leading to the short ear canals, that is leading to recurrent infections. So there's an infection of your nose, ears, that can be causing a block and causing hearing problems. So that can be hampering the speech or language development. So when something is going fine and then you see things are deteriorating or becoming a plateau, when you're looking at other causes, this is one of the important things to bear in mind. Sleep disorders. Again, with these features of the hypotonia, the tongue, the hypoplasia, they're at more increased risk of sleep disorders. Again, like all of you know, sleep is a major factor contributing to behaviors, learning. So if they're not rested well, they are not in their best ability to learn and progress. So this is also something to keep in mind when we are screening them. Hearing loss. what we have spoken about the infections, that is a very good, very common occurrence in these children. So it is more so of conductive hearing loss that is happening here. And hearing screening is done to all newborns, but with Down syndrome, it is very good to have it every 6 months, 12 months. And after that, based on what their clinical conditions is, it can be repeated. Blood disorders, again, are very common, but if you're seeing that the child is feeling very tired, their performance capacity is not as before, something is changing, then it is always good for a pediatrician to look into these causes as well. Some are get treated spontaneously, some need a treatment, but the good thing is they are very well responsive to therapy here. So there is good hope for these children. Again, vision. They could have squint, they could have this duct that is blocked. So the tearing of the eyes is very common, infection of eyes, cataracts could be seen. Again, these can, visual symptoms can also hamper their physical development and academics, reading, so many things. This could cause problems. So keep look out for them. Again, low risk, there is risk of epilepsy, celiac disease, but they're very, very rare, just to have them at the back of your mind. So in summary, what do you do? How do you monitor these people? If you look at this timeline, I think this sums up whatever I've been talking. At birth, genetic confirmation. So getting to know the underlying cause there, thyroid function test, echo to rule out any cardiac disease, and then a hearing test. And then at every vaccination, their developmental milestones and their height, weight is all monitored. At 6 months, again, thyroid function and formal development assessment. Again, development assessment, I'm sure all of you are aware that they have their own set of development patterns. It is not the generic ones that we use for routine. So that is something to look up if you're not aware. Again, at 1 year, what you do, and every year, annually, thyroid test, hearing, vision, when there are issues you're looking at. And echo is not something you will be looking after, but sleep and developmental assessment is overall developmental assessment. So to look at which all areas they need support. Okay, so in summary, it is generally the hypotonia causing a lot of these problems in the physical development. The other problems that could be caused is due to the ear infection, obesity, snoring, glue ear. So these are all what is happening. Okay, so as the saying goes, forewarned is forearmed. The whole reason for this is so you get a general idea about what are the medical conditions or issues that can be happening here, and to look out for and direct the parents in the right direction. Some of these parents are only seeing you, they might not be seeing others. So it is very important to keep your ears and mind open and look out for these things on a regular basis. And when we kind of support them in these other medical issues, you will see that how well they can actually respond to the other therapies, what you're doing. Okay, so I will stop with this here, and I will now hand over to Ms. Brinda to continue.
Thank you, ma'am. Thank you very much for that lucid, simple presentation. I think the summary was really good because that's what people will understand at the end of the day. And, it was so crisp. Thank you very much. Now we'll move on to the therapy sessions, and we will begin with counseling by Dr. Surekha Ramachandran. Dr. Surekha Ramachandran is the president of the Down Syndrome Federation of India. She is popularly known as Rekha Ma because she's a mother figure for anybody and everybody who has a child with Down syndrome in the country. Not only in the country, even abroad. So, and she has over 40 years of experience, and is probably one counselor who has seen almost 7,000 children. She has counseled almost 7,000 parents. And with all this experience, she's ready to share it with us here. Over to you, ma'am.
Good evening to all these beautiful young people. I feel so good and energized when I see young people all ready to work for the cause. Yes, we are here today to celebrate the World Down Syndrome Day. And we keep using the word Down syndrome. I like to call them trisomy 21s because it gives us a big status. This is the most common abnormality in newborns and the commonest cause of intellectual disability worldwide. Down syndrome, my friends, includes a combination of both physical and neurodevelopmental impairments characterized by specific facial features. We also found out that later on, most of these children start to resemble their parents. And when the doctors first come and tell you your child is a person who has mongoloid features, we start searching for the features rather than looking at that the child definitely has more of me than the mongoloid. So, I will also take you through all of that because, the parents tend to get diverted by this word and the fact that, oh, the features are different. The features are not really that different. They will have a little bit of, the flattish nose and the ears and things like that. But we don't give that much importance because the parents, basically, when you ask them, did you see anything wrong with your child? They'll turn around and say, to me, the child is perfect. So why do I confuse the brain by going into telling them that your chromosomes are all abnormal? Let's put it like it's perfect, because half the issues start when you start thinking your child has an issue. The prevalence in India of persons with trisomy 21 is 1 in 750 to 800 live births, which actually tantamounts to being 29,000 to 30,000 people being born every year with Down syndrome. Also, my friends, we don't say Down syndrome baby. We don't say Down syndrome person. We say persons with Down syndrome, because that can become a very big issue on an international platform where you will not be allowed to speak more than one line when you make the Down syndrome bigger than the person. Please remember this, mark it, put it down on. The role of the Down Syndrome Federation as a primary body to counsel and support the parents, that's all we do. That is my responsibility, that I have to make them feel absolutely perfect and that they are on the road to recovery. What do parents with Down syndrome children, persons with Down syndrome experience? It's common for parents of babies with Down syndrome to experience shock, sadness, fear over the unknown. We are all in that bracket. We don't even know what is in store for us. So unless you actually put it down and tell them that there are people to support you, we are all here to hold your hand, they can lose hope. Serious health issues can add to the panic. About half of our children born with Down syndrome have heart defects. I'd like to take you back 40 years ago or 42 years ago when my little one was born. So I remember the time when the doctor said, your baby has Down syndrome. Now, I'm sitting on this couch with tears coming down my face, feeling that the world is crashing. And I know that every parent goes through the same feeling of helplessness and hopelessness. Upon receiving this diagnosis, I remember feeling a sense of a soul-crushing hopelessness. Hopelessness for what my daughter's life would be like. I know that every parent goes through this. The diagnosis is just one part of it. It does not, hopelessness is there in every family who would look for hope outside their own families or from us. I, at that moment, was completely changed when I heard that my daughter was going to be different. Now, looking back 42 years ago, I want to replace all that anxiety, sorrow, and anger with different emotions. That's because it took so much time for us to come to realize that this is my child. First of all, my friends, I want to explain to you that if there is one thing that a person cannot handle or cannot accept, is their child will never be what the world calls normal. It's very difficult to relate to something or somebody who says your child is not going to be like other children. It's the world comes crushing down on you. I know that I had in store This fear that my child would have a zero potential. She would never be able to do anything like everybody else. But today, it is very different, very, very different. I can tell you, after being through what I have, I can tell the parents very clearly that they can look forward to an amazing future for their child. I would also seize the chance to tell every parent that their child is special, but the child will do everything that other children also do. So remember that, make a note of it. I take pride in also being able to stress and elevate all the anxiety that I see in the parents. I use five pointers that I normally do. The first thing is your baby is a baby. It is not, you've not given birth to a Down syndrome baby. You've given birth to a baby who's unique, and you will bear all the resemblance that you have in your family, and all the characteristics that come along with it will be only yours. We do not, and also the baby will still achieve typical milestones. That's very, very, very important. The milestones will take a little longer, but with the amazing therapists that we have around us, we are able to achieve and take them and guide them through all of this. The celebration that you get by your child achieving this is much higher than anybody else who's a typical person. My daughter spoke her first word when she was 11 years. But it paid to be patient and not lose hope. There is support and help available all across the country today, and we have support groups in every part of India. The support for the parent with the child with special needs is there. You can enroll your little one in early intervention groups, which is formally the most important thing for a little child. What does it work like? First, we need the medical intervention. You all know the number of medical issues that we look at when we have children. There are multiple issues, and they tie up with the professionals, including speech pathologists, occupational therapists, physical therapists, play therapists, special educators, and feeding therapists. Your child will begin therapies to help them reach milestones faster and correctly. Your baby will also experience a wide range of emotions. We were always told your baby will be a happy person. We've disproved all of that. You can see that around you. None of our children are just happy anymore. They want to be everything that you guys are, which also seems, so first when they said that, I thought, oh my God, is she going to just be smiling? But the truth is they display every mood in the rule book. Happy, sad, silly, angry, whiny, hysterical, delighted, and my daughter can be absolutely annoying. These are all the things that we have seen with them, and it comes on very strongly. If you believe that they will, they will. And this is actually just like any other individual. When they come to me and say, oh, my child is very stubborn, I said, look within the family. Is your husband stubborn? Are you stubborn? So the child also will be stubborn. Down syndrome does not define your child's entire existence. It does not. The huge bit of news will not overshadow your whole life and will eventually slide into oblivion. You will forget the child has either trisomy or Down syndrome or whatever it is. You will not remember it. I don't remember that my daughter has anything different because she is just like my son. You will have bad days. That has nothing to do with the diagnosis. You will laugh. You will cry. Again, over other things. You will also enjoy a lot with your child that has nothing to do with chromosomes or therapy or doctor's appointments. Children with Down syndrome, my friends, have a risk of congenital defects and organic disorders such as congenital heart disease, hypothyroidism, visual and hearing impairments. We all know, we are seeing that every day, and we insist that all these tests are done at least once a year for us to be working very closely with them, with a team and a band of amazing therapists that Down Syndrome Federation of India has got on team. We are actually trying to rule India and run through everyone's lives by giving them hope, by making them feel amazingly well. We just need all the society also to sit up and say, yes, we are there. The One-Stop Down Syndrome Federation of India service was inaugurated in 1984. And to create this clinic that works very closely, we call ourselves, our center is called Matru Mandir, which is the mother's temple. I'm sorry that the fathers don't have a role to play in this, but today the fathers are as active as the mothers. and we can review the child's development every year. And it is working very, very well. We bring them back. Sometimes we lose track of our children. Once they get into school, they don't come back to us. This is what we want to tell you. Please come back every 6 months, have a review of your child, because when you lose track and we lose track and you come back after 20 years, we have lost that interim period of what happened, why the child is no longer where it should be. So these are the small tips that I want to give you. And our entire life has been to make our the parents comfortable, live an absolutely happy and very, very, very it's not so much as comfortable. I want them to understand that we are holding their hand and guiding them through the whole thing. Please don't give up hope. And you can always reach our therapist at any point of time, because ours is a multidisciplinary team that works hand in glove with the medical teams. Thank you so much for hearing me out.
Thank you, Rekha ma'am. As usual, another powerful presentation. Very interesting. I'm sure none of them would have moved from their screens. And I'm sure everybody would have understood. I would like to inform you that whatever questions you might have, please keep it for the end. Do note it down and put it in the chat box. And someone would be guiding you at the end of the entire presentation. After Dr. Surekha Ramachandran, we have our physiotherapists from the Down Syndrome Federation of India, Ms. Sri Lakshmi Ramakrishnan and Ms. Mithula Vijay Kumar, who would be taking us through the physio aspects of Down syndrome. And I would just like to give you a brief about both of them. Ms. Sri Lakshmi Ramakrishnan is an experienced physiotherapy practitioner, and she has experience across multiple hospitals and healthcare clinics in Chennai. She is a pediatrics expert, and stroke rehabilitation, neurological conditions, geriatric healthcare, strength training, and injury prevention are her strength or core areas, you may call it. She is also specialized in early intervention for children with Down syndrome and other disabilities, and is an aquatic therapist too. She is very proficient in exercise prescription for toddlers with Down syndrome based on NDT. And she is a licensed dry needling practitioner. So that is all about Sri Lakshmi. Mithula is a pediatric physiotherapist. She's been working with the DSFI for the past 7 years. She has experience in NDT and in aquatic therapy. She's even published a paper in aquatic therapy regarding the benefits of aquatic therapy in toddlers with trisomy 21. So with these few words, I hand over the mic to Sri Lakshmi and Mithula, and they will be taking over. Over to you, ma'am.
Hello, this is Mithula Vijay Kumar. I'm a physiotherapist from DSFI. So my topic for today will be core stability in toddlers with trisomy 21. Shall I share my screen, ma'am?
Yes, I think you should be able to share your screen.
One minute.
Yeah, no worries.
Ma'am, is my PPT?
No, it is not visible. Now it is visible.
Now it is visible, ma'am.
Yeah.
So I'll be talking about the effect of core stability exercises in toddlers with trisomy 21. So what is core stability? So core stability refers to the strength between the abdominal muscles and spine muscles, which is back muscles, and the amount of balance between these two muscles. Without this balance between these two muscles, the toddler with trisomy 21 will not be able to achieve sit, crawl, walk, jump, hop, and run, which is required for their daily activities. So core stability is built when the child is born, and the strength in the core muscles is built when the child starts moving around and when they start to explore their environment. So why core stability is weak in toddlers with trisomy 21? Toddlers with trisomy 21 are born with a low muscle tone, that is hypotonia, and will have a less core stability due to their weakness in the muscle tone, and will find it harder to build their strength in their core muscles. The abdominal muscles is in particular will be very weak. Due to weakness in the core stability, their milestones like rolling, like neck control, rolling, sitting, crawling, standing, walking, jumping, hopping, and running will be delayed. Most toddlers with trisomy 21 will avoid the rotation movements because due to their low muscle tone, that is hypotonia, and they will either move in a dimensional manner, that is backward or forward movements, and or side to side to develop strength in their core muscles. Why is it important to develop the core stability? The core muscles have two main functions, that is to spare the spine from taking the excessive load and to transfer the forces from lower body to upper body, and to prevent injuries and for postural stability. Due to weakness in the core muscles, toddlers with trisomy 21 can have musculoskeletal disorders and pelvic stability, pelvic stability, instability, and ligament laxity, etc. Benefits of strengthening the core. The benefits of strengthening the core stability in toddlers with trisomy 21 at an early stage will help in achieving their delayed milestones from neck control till they start walking, jumping, running, etc. Core stability will also help to maintain the postural stability, which will while playing and communicating and exploring the environment around them. Ma'am, I'll be talking about the main core stability exercises which we practice in our center. So the main core stability exercises are tummy time, rolling, hip raising, lying on their side, lying to sitting, sitting on gym ball, crawling, and standing against the furniture. So tummy time is an important this thing for core stability, which makes the neck and the shoulder muscles stronger, so your baby can start to sit, crawl, and walk. It also helps in improving the gross motor and fine motor skills in toddlers with trisomy 21. Next is rolling. It combines the movement of both upper extremities and lower extremities in a coordinated manner to move from one posture to another. The main other one is hip. Hello.
Ritika, can you mute them?
I think someone is Unmuted.
Hello, ma'am. Can I
Yeah,
continue?
you can continue, ma'am.
Hip raising. Hip raising, it improves the core muscles and the pelvic floor muscles. So, to bring the pelvic stability in toddlers with trisomy 21, to improve the gait pattern while the child starts walking. Crawling, it is an important milestone in toddlers with trisomy 21 because it helps to develop the vestibular and that is the balance system, the sensory test system, and the cognition, and in problem solving skills and in coordination. Once a child starts walking, we proceed for the other core strengthening exercises, which will help in jumping and running, which is delayed in toddlers with trisomy 21. Superman, this core strengthening exercise is is followed after the child starts walking. This Superman posture plays a vital role in developing the anti-gravity muscles to strengthen the child's head, neck, arm, leg, and trunk muscles. This particular form of exercise develops in the vestibular system, that is the balance and the body awareness. Crab walk, it is a great exercise that promotes balance, motor skills, coordination, and cardiovascular health. Wheelbarrow. This helps in the coordinated movements of the upper arms and the lower extremities, which will help in the fine motor as well as in gross motor skills. As I'm practicing aquatic therapy, I will update regarding the benefits of aquatic therapy in toddlers with trisomy 21. So the benefits of aquatic therapy for the children with trisomy 21, which helps to improve the gait, balance, and coordination in children with trisomy 21. So what the properties of water, that is the buoyancy, which the hydrostatic pressure and the fluid resistance, when utilized in aquatic therapy, helps to improve the tone of the muscle, as toddlers with trisomy 21 has low muscle tone, and it has shown a great improvement for the delayed milestones, which is required for the daily activities, and to improve their posture stability when the child starts to walking, and also improves the gait. Thank you, ma'am.
You could stop sharing, ma'am. Thank you. Thank you for that wonderful session, ma'am. I think now Ms. Sri Lakshmi can take over. I would just remind everybody, if you have any questions, please put them on the chat box, and this will be taken up later. Over to you, Sri Lakshmi, ma'am.
I'm sharing my screen. I hope it's... Yeah. So the topic today is physiotherapy as early intervention in a multidisciplinary team for children with Down syndrome. I hope I'm audible.
Yes, you are, ma'am.
So I'll go on. So early intervention team for children with Down syndrome is physiotherapy, speech therapy, and special education. But the therapy program always begins with physiotherapy, then speech and special education session. Physio session starts right from the age of 2 months. The prerequisites to start physio session is cardiac screening, because it is very important to know the heart condition to prescribe exercises accordingly, to decide on the repetitions and counts of exercise. Depending on the hole size, conservative or surgical management is decided with 6 months of screening intervals, which is done. In case of surgical conditions, physio sessions can be continued or started after 2 months. And thyroid is another important screening to be done in children with Down syndrome because it has very direct effect on the child's physical and mental development. So that's one other screening which is done apart from the basic other ENT and other respiratory screenings. So me as a physiotherapist, I look at the development in 3 stages, or rather to say, I look at the physical development milestone in 3 stages because it's easy for me to work on to bring on the quality in movement. So my exercise prescription would be to work on both, integrating 2 aspects of the development. Like in stage 1, I work on the neck control, sitting balance and stability. And in stage 2, I work on the crawling, standing balance and stability. Stage 3, I work on the walking and jumping. So it is not that when we work only on a milestone, we work on 2 milestones in order to bring in the stability and better quality of movement, which is more important to me. So I don't look at it at what stage the child, at what age the child attains, because the very concept of early intervention to speed up the process. So once the child is into the system, that is already there. So as a therapist, my priority would be to bring in the quality of movement, because what the parents want to look into is the child has to get integrated into society. The way he or she walks or moves, it just have to be fine. So let's look into what are the structural or orofacial myofunctional disorders in children with this Down syndrome. They have a narrow and high heart palate, shortened elevated upper limb and hypotonic, averted lower limb, open mouth posture. Because of this, they have a mouth breathing pattern and there's a lot of drooling. And malocclusion, which is upper and lower teeth don't align when they close their mouth, and they have tongue protrusion and jaw protrusion. So generally it is termed that they have a large tongue. It's not so. It's because the narrow oral cavity and the hypotonic nature of the tongue often protrudes out, and not because they have a longer tongue than us. And then it's the poor neck and head control. So all these combined features have a direct impact on the body's center of gravity, so resulting in a poor or reduced postural control. Clinical evidence suggests that these issues can be improved by therapeutic interventions. So how does, so since we are looking into a multidisciplinary approach, so I would, carry forward my presentation in the same aspect. So how does a physiotherapist intervention help a speech therapist, or how does both the professionals can complement each other or work to bring a better result and a faster result in a child? Is like neck and head control exercises and sitting exercises help in postural control and stability. The orofacial myofunctional therapy, known as OMT, focus on the oral physical problems, especially involving the tongue, that prevents normal speech development. Postural control is a prerequisite of OMT. So meaning, if the child cannot hold head upright with good neck control and sitting balance, OMT cannot be performed. So it is very clear that the neck and head control is very important to move forward. The next part is how a physiotherapist and a special educator working together will help the child. So the things that I would be talking about is jumping, bilateral coordination or integration, midline crossing, and independent in ADL. So why jumping? Well, jumping is a building block for more complex movements, specialized skill, and generalized activity. It requires balance and strength with the awareness of body. And bilateral coordination or integration? Well, it is the ability to coordinate and use both sides of the body at the same time in a controlled and organized manner. It includes doing same thing, alternative movements, or using different movements on each side. It is an indicator that both sides of the brain are communicating effectively and sharing information well. Important foundation in the development of bilateral coordination is body awareness. So what kind of activities require bilateral coordination in a child? Jumping a rope, kicking, throwing, catching a ball, riding bike or trike, walking, running, crawling, cutting, pushing and pulling, stringing beads, drawing a line with a ruler, banging blocks together, trying to tie a shoelace, dressing, feeding oneself, coloring within the boundary. You know, it's a prerequisite, or that's something what preschoolers do, coloring within the boundary, preschooling, starting their schooling. And what is midline crossing? Well, it is an integral skill related to bilateral coordination. It is vital to promote the coordination and communication of the left and right hemisphere of the brain for controlled and complex movement. So how does midline crossing affect schoolworks? Well, poor midline crossing can cause the child to have a scattered attention. Movements that cross the midline are important for fine motor skills, directional skills, and for interpreting symbols, like identifying letters and numbers. Avoiding confusion between letters like B and D, this often happens. So that is something related to it. Then why is crossing midline important for writing or handwriting? It is important visual perceptual learning, as well as the coordinate use of both sides of the body and doing hard while certain activities. Is midline crossed while reading and writing? Yes. When we read and write from left to right of the paper, crossing the page, the eyes in a continued movement, the eyes must cross the midline in order to do this in a most effective way. So without jumping, bilateral coordination and midline crossing skills, it is difficult to work on the awareness of body spacing and boundaries, which is incorporated into writing and reading skills in a child with Down syndrome. So to end my slide, I would emphasize on the multidisciplinary therapeutic approach, because professionals under the same roof set strategies aiming to integrate goals for more than the discipline and boost results. Although professionals may integrate goals and even join the sessions, each therapist has a well-defined role restricted to their area of knowledge. In this approach, therapists' roles are divided but applied in symphony during the sessions and provide a practical blend between resource investment and client outcome. Integrating goals have proven to promote stability, breathing coordination, and core muscle strengthening in a child with trisomy. Thank you.
Thank you so much, Sri Lakshmi ma'am, for sharing your experiences. I am sure it would be a great learning experience for all the therapists who are present here today for the session, and for everybody else too, because we also learn new things. And thank you very much for that presentation.
Thank you for the opportunity to be here.
After Sri Lakshmi ma'am, we move on to our next specialist, Ms. Hemamalini Saumitri. Hemamalini Saumitri ma'am has been with the Down Syndrome Federation for years now. She is a special educator, and she has done a lot of work with children with trisomy 21 and other special needs too. And to be frank, the most popular special educator for DSFI is Hemamalini, because anybody who calls asks only for Hema ma'am, because her advice has helped a lot of children start going to school and perform very well in their lives. So without much ado, I hand over the screen to Hemamalini ma'am. Ma'am, over to you.
Thank you. Thank you so much for the wonderful introduction. And I'm so happy if others have benefited through me. Okay, so let us go on to the presentation now. Is it visible?
Yes, ma'am.
Okay, right. So let us talk a little bit of special education. Really, I was so happy to listen to our physiotherapist talking so much about the core strengthening, how it benefits the child in so many other areas. So now let us move on to how exactly even I feel special education is nothing but is a combination of all this. We cannot work in isolation at all. We need to work together. That is why probably we call it as multidisciplinary, and it is a must for every child for the whole holistic development. That is how I always felt during my experience while working with children. So how it happens? Listen, look at the basic activities of the daily living, which is the early intervention, is a part of early intervention strategies where we expect the child to learn to eat by itself, to drink from a sipper or a straw by itself, and use toileting. This is very important. So this is more important than coming to the academic skills, because at an early intervention stage, where the child has not even entered a school or not even ready for a school, we need to expect this from the child. The child has to learn to do few things independently, not everything, but at least the few things. So this is the part of the early intervention which we call under the special education. So again, the core muscle strength is very important, just as our physiotherapist Mithula was explaining, using different exercises. Then comes the receptive and expressive language development. So as the child is growing from 1 year to 2 years, we expect the child to learn many things. So how does this happen? Only when the child is exposed to a peer group, a group of children, through different stimulations, this is happening. So apart from a peer group, there's also an individual therapy that happens along with the peer group. So what really happens during this kind of increased stimulations is the child learns to either first listen, then talk. So this is a combination of speech therapy, definitely. But when it comes to special education, we call it as a learning methodology through peer learning. So the child needs to be exposed in different environments so that the child learns to listen, speak, or at least imitate. Then what about the non-scholastic behaviors? Even before going to scholastic behaviors, that is the pure academics, it is very important to learn about this non-scholastic behavior, because this, as Sri Lakshmi was just now telling, this exactly develops the brain. The midline crossing, the movements, the posture, all this is important for the academics. But just jumping into academics in the early intervention is not really correct. So let us go stage by stage, non-scholastic movements or the dance, the action rhymes, the sessions through exercises, simple, very simple exercises, the body balances. There's various amounts of games, very small games that can be brought in so that the children will learn all these things and develop a stable body so that the posture can be enhanced and maintained while they get into the academic part of it. So coming to the academic part, now from the non-scholastic, moving on to the academic, if I have a better eye-hand coordination, if I can have a better midline crossing and then better posture, this is definitely going to become easy. My wrist, elbow, and shoulder needs this amount of strength to hold on a pencil or a pen or a crayon. So how does this come? This comes through a physiotherapy as well as a lot of play methodologies that can be used as an early intervention methodologies. That is, this is all these things becomes a school readiness. A child cannot just like that go to school without being ready for it. So ensuring that the child gets all these things through different therapies is very important so that this can be achieved. So here we are exactly looking at fine and gross motor along with cognition. The child is expected to point, the child is expected to look at things, the child is expected to dance and show movements for the rhymes, and then finally the child is expected to write. So all these things happens when the muscle strength is happening, as well as good communication is also learned. So all these things happen hand in hand. It cannot happen in isolation. And reading and playing, this is again a wonderful thing where the child has to read. Yes, the child has to read, but the child need not be learned always in a boredom. The child can play as well as read. So how does this play come? This play is a part of a therapy called as occupational therapy, where the child is learned to wait for the turn and then move on. So though occupational therapy and physiotherapy goes hand in hand, few behavioral patterns is also taught in an occupational therapy. So at play comes to a special education, but then it comes through various modulation from occupational therapy, speech therapy, physiotherapy, and then finally ending up into the education or the academic improvement. And then finally the social skill development. This is very important. Mostly said that children with Down syndrome has got very good social communicative abilities, but then to enhance it into a proper way and then to bring them back into the society is very important. Again, what do we need for this? A very effective motor skills and a very good communication skills. So again, I'm relating it to the therapies or the physiotherapies, the occupational therapy, and then the speech therapy, all put together, and then the special education, bringing the children into the school, into an inclusive society is what is happening, wherein the child learns the social skills. So the body spacing and independent living, the body spacing is also very important where the child while playing is waiting. It's not actually pushing the other child in a slide. So this is the body spacing the child needs to understand. Where does this come from? This comes from the therapy centers. This actually, the child will be made to wait while one child is having a therapy. There the child has already learned it. So when the child is being included into the school system, that is, it is again a non-scholastic, but a very important part. So when the child comes to the school system, the child needs to wait for the child who is already in the play area. So this kind of environment will only enhance social skills in the child. Here it's the eating time, the time where the child has learned not to grab from the other plate or probably learned how to share things. So this is the communicative part, where here we are talking about the motor and the communication. Here again, we are talking about the motor as well as communication. So building self-confidence through the abilities is what is achieved in a special education when the child is learning all these things through a multidisciplinary team. So what we have achieved as a holistic development, and the child claps for himself. We need not always clap for the child also claps for himself. This is how I end the slide. Thank you.
Thank you so much, Hema ma'am. As usual, simple, crisp, precise, crisp. That has become your trademark. So every session of yours always has these crisp slides and you explain it so well. Thank you, ma'am. Thank you so much. Now I invite our next speaker, Dr. Sharanya Krishnan, who's a speech therapist. She is a multi-talented individual and has so many credits to her that I think we will have the whole session just describing Sharanya ma'am. So without much ado, I hand over the mic to Sharanya ma'am, a topper all through her life and a topper even now because she's the most sought after speech therapist as far as Trisomy 21 goes in the country. Over to you, Sharanya ma'am.
Thank you, Brinda, for your warm introduction, lovely introduction. You're being too kind.
It's the truth, ma'am.
So I'm just sharing my presentation. You know, I'm technically challenged. So just tell me if you're able to see it.
Yes, ma'am. Absolutely clear.
Ready and open so that I don't fumble. Right. So over to speech and language, understanding challenges in Down syndrome. So this is the topic. And since we have a mixed group of audience today with parents, professionals, young professionals, probably students, I will touch upon relevant aspects today. So we will start with those factors that impact learning, language learning. So the first thing that I would like to highlight is sensory abilities. Obviously, if vision or hearing is affected, then the input that goes into the child, okay, the language input is going to be affected, right? So sensory ability is a very, very important factor. So we have to make sure that screenings are done. Screenings and, tests are done time to time. It's not just, screening once and, you get a pass and you let go. Children with Down syndrome do have, difficulties with respect to vision. They could have, strabismus squint. They could have, hearing disorders, which could cause a temporary shift in their thresholds. So otitis media, for example, when they have blocked ears, fluid-filled ears, constant upper respiratory infection, all these things would cause a temporary shift in their hearing thresholds, which will impact language learning. So it will impact the input that goes into them. The second factor that I would like to highlight here is pre-linguistic skills. So what do you mean by pre-linguistic skills? The basic building blocks, the basic foundation skills that are required for language learning. Okay, so this could be attention, joint attention, concentration, sitting tolerance, turn taking, eye-hand coordination. All these things form the basis of learning any skill. Forget language, it could be any skill. Okay, so these are the next set of skills that are considered very important. The third one is comprehension. I would give a thumbs up for comprehension, because persons with Down syndrome in general comprehend a lot. Okay, and in my clinical experience of about 18 years that I have seen these children, I find it extremely interesting to work with children with Down syndrome, and because they are a very, very easy bunch to work with. Why do I say easy bunch to work with? Because they are no different. They're hardly different from neurotypical kids. Okay, so when you work with them, it's a lot of fun. It's a lot of interaction. They are so proactive, during the session. So it's very interesting and a lot of fun to work with them, only because they comprehend a lot. They are able to understand most of what is said to them. Okay, now the next most important factor is speech motor difficulties. Why does speech motor difficulty arise in the first place? So we all understand that children with Down syndrome have anatomical differences, okay, in their oral cavity with respect to the size of the tongue, size of the oral cavity, the position of the tongue being thrusted in the forward like this. Okay, a little front placement of the tongue, muscle tone differences, okay, some amount of low muscle tone, flaccidity. All this is also seen in the mouth as much as it is seen in the extremities, as much as it is seen in the legs, hands, trunk, core, fingers. It's there in the tongue muscles, it's there in the oral muscles also. That is also the reason why they could also have feeding difficulties. Okay, so speech motor difficulties is the next factor, and language learning situations. Okay, now let me tell you that there is a high degree of variability when it comes to this factor, because despite individual differences in intelligence and other abilities, in general, children end up learning to speak and understand their native language. Okay, be it a Marathi, Kannada, Hindi, Tamil, whatever it may be, children are able to pick up languages, with different levels of intelligence and other abilities. Somehow they end up doing it. But this largely depends on one important factor, which is language exposure. Are you exposing the child to language, to enough language? Is the language learning, it's going to be robust if the child is exposed to a lot of words. So the more you talk to the child, in very simple terms, let me tell you, the more you talk to the child between 0 and 2 years, the better is going to be his or her language development, okay, language learning. So they're going to pick up more words. Basically, you act as a model. So, and they imitate the model. So the more you talk, the more they learn. Okay, so these are the few basic factors that impact language learning. Okay, and moving on to therapy, what is the role of a speech pathologist? What do we do? What is expected of us? What is required of us? We provide evaluation, okay, and treatment for the speech and language difficulties. So you evaluate, you diagnose, you list down the difficulties, you assess the child, and give you set a baseline or a goal. Okay, develop a comprehensive treatment plan to address all of the areas in which the child may be experiencing difficulties, and your goal plan should cover all of it. It is not like you work on pre-linguistic skills for 3 months, then go on to comprehension, and then for the next 3 to 6 months work on comprehension, and then move on to expression. It just doesn't work that way. You have to have your goals equally spread out, with weightage given to areas where the child has more difficulty. So if the child can comprehend really well, you don't have to lend so much focus on comprehension. If the child has more of oromotor issues, focus more on oromotor, but don't let go of the comprehension and expression part. So your therapy plan should have, all the aspects covered simultaneously. So in a given therapy session of say 30 minutes or 40 minutes, time should be allocated for each of these goals. So work with families. The next role or responsibility of an SLP is work with families and teachers to design and implement an effective school, home, and community program. Okay, so what we are looking at is something that is comprehensive. Okay, something that helps the child settle, go beyond the clinic. So you have to extend your wings beyond your clinical setup. Okay, so you have to work with the family, work with the school teacher, and because children with Down syndrome are ideal candidates to fit into an inclusive school. They don't often need to be pushed into special education at all. So our therapy program has to be designed in such a way that they are able to settle in school and the larger community very well. Okay, so it basically has to be tailor-made. In other words, what fits for one child will not work for another child. So it has to be based on the cultural background, the values, the school that the child goes to, the community that the child lives in. So it has to be tailor-made. Now, what are the stages and goals of therapy? So as I said, I broadly, divided this into 2 categories. Okay, the first one being early language learning for younger children, say 0 to 3 years, or 0 to 4.5 years also. And the second part, speech production. So these are 2 different aspects of, therapy. So early language learning will focus on the pre-linguistic skills that I listed a while ago. Comprehension, that is understanding and creating a corpus, creating a bank of words, vocabulary in the child's brain, which it can utilize for verbal expression. Third, verbal expression. Now, we all know that children with Down syndrome have this amazing ability to imitate. They imitate everything, your body language, facial expressions. Many of them turn out to be wonderful dancers. That's because, and they don't have inhibitions or stage fear, and that's because of their amazing ability to imitate, and when they are able to imitate all these things, body movements, facial expression, and everything, we have to presume that they have the ability to imitate words also. But there is one challenge. The challenge is oromotor difficulties. Okay, that is what kind of, comes as an obstacle between the imitation and the production of words. So verbal expression becomes a very important part of your therapy, and you have to somehow work towards pulling the child out of its comfort zone of gesturing and pointing and all that, and get the child to understand that speaking is easier than, nonverbal communication. The other important aspect of early language therapy is auditory perception and listening skills. As I said, many of them do have difficulties, in their sensory abilities. So it is very important for us to work on, listening, perception, and the ability to listen and execute commands, okay, not just one step command. Go close the door is a very easy thing for them to do. And especially when you say go close the door, you're looking at the door, you're pointing at the door, and they get all these cues. They're so smart that they, put all these cues together and then go finish the command and come. Okay, but if you say go close the door, bring the ball and keep it on the table, there you see a struggle. Okay, because you have no cues, visual cues. You don't, your hands and legs are not moving. Okay, you need to sharpen their listening skills. So listening to series of commands and executing them. Execution part, they don't have the problem. They have a problem in listening to extended auditory commands. Okay, so that is something that we would have to work on. For the older group, say 4.5, once they start, expressing verbally, we go a little aggressive on their oromotor exercises, work on range, flexibility, endurance, and strength of tongue movements, work on articulation, that is proper sound production. You do a sound profile, you analyze the sounds that are errored, the context and situations in which the sounds are errored, which are the, what patterns can you see in their, misarticulation. List all that down and work sound by sound. And progress in a very systematic manner, where you start with the sound production, show them the, place of articulation, teach them how to produce the sound, then go to syllable, word, phrase, and sentence level. Another common challenge that older kids with Down syndrome face is generally stammering. They tend to, develop stammering. As I said, they are no different from neurotypical kids who are developing typically, because they are very high on emotional quotient. The social skills are on par with typically developing children. And so are there, whatever comes with adolescence, hormonal changes, tantrums, anger, all these things, will be like any typical 12-year-old or 13-year-old. Okay. So when it is sort of overwhelming for them, fluency could get affected. Okay. When anxiety sets in, stammering could also, be seen. So tackling fluency aspects is also another part of speech therapy. So what are the general strategies?
To just, I'm sorry to cut your flow. Yes. You have 1 minute, ma'am.
Yes, I'll be done.
Thank you. Yeah,
yes.
Thank you. Yeah.
So what are the strategies? You have to accelerate vocabulary comprehension and production. Take into account the auditory aspects, short-term memory, and muscular weakness during therapy. Always keep that in mind. Reduce the effects of hearing loss by monitoring them constantly. Capitalize on the child's good social interactive skills. Improve articulation and phonology. Now, what are the success factors? Presence of parent in the session. Therapists in this group, this is a humble request, okay, to keep the parent inside your session. You don't lose anything. You share knowledge and experience with the caregivers, and parent involvement and motivation of the therapist go hand in hand. And there are no better therapists than parents. And you can see great success when you transfer, the responsibility to the parents and they start working with the child at home. So set realistic goal plans, ensure regularity, give effective home therapy programs. Don't give them, over the top exercises that are difficult for them to do. Set simple targets for parents to do at home. The stimulus response reinforcement paradigm works like magic with Down syndrome, okay, children with Down syndrome. So work with a lot of positive reinforcement. Redundancy and repeated practice will surely give you success. So our vision as rehab professionals, okay, is to build long-term relationship with the family, work as a team, include the parents and caregivers in the session, work in tandem with other therapists and professionals. Don't do something, in a tangent. Work towards inclusive education. That's the final goal. We have to create confident and independent individuals and help them survive in the society and improve their overall quality of life. Thank you so much for listening.
Thank you so much, Sharanya ma'am. It was an amazing presentation. I'm sure there are a lot of speech therapists here who would benefit from your presentation, learn a lot more, and I'm sure many of them would have doubts which they would be asking now. So right now we move over to we come to the end of the presentations and move over to the Q&A session, which would be handled by Kritika. So I hand over the stage to Kritika. Kritika, take over, please, for the question and answer sessions.
Hi, good evening, one and all. It was, firstly, I could say it's such a beautiful presentation which all of y'all have done, and it was so nice to hear, multiple perspectives. And one thing I personally enjoyed was everyone said, yes, involve the family, involve the parents, which is definitely required. I myself as a therapist definitely know that is something which is the most important thing for the child. So we have two questions out today. So the first question is to Sri Lakshmi ma'am. Children with Down syndrome are prone to respiratory infections and also very commonly to ear infections. Are there any precautions that can be taken to prevent these two things specifically?
Yes. Initially, we do all the screenings before the child come for aquatic therapy, so that we make sure that, from the medical end, it is all fine. And then, as far as the sessions of whatever I've done, I haven't come across with much ear infections and thing. If we take all the precautionary measures, like, you're looking into what kind of pool, you're not going to use the water quality and all that. I think that would do with preventing. It's more of a preventive measure that we have to take as therapists, and certain things that we need to inform the parents. So that's all. I think I've answered.
Thank you, ma'am. Another question again addressed to you is dry needling. There is a lot of research ongoing on integrated medicine. Is there any scope or research in the management for children with Down syndrome or people with Down syndrome related to dry needling?
See, dry needling is just an adjunct that you can use for, pain management. So it is not that the approach. So I think I haven't used much with children with Down syndrome, but yes, it is more useful in a spastic condition, but not in a hypotonic condition.
Yes, thank you, ma'am. The next question is out to Sharanya ma'am. It is, can you please elaborate a little on how the oromotor difficulties with the tongue would be addressed? And can clear speech be achieved despite their anatomical differences?
Yeah, let me be upfront. Anatomical differences are there, so we only have to work against the odds. But the ultimate goal is to get a stranger or a third person to be able to understand what the child is trying to communicate, what the person is trying to communicate. Now that is the final goal. Okay, so you may not be able to achieve 100% clarity like the way you or me talk, but yes, the goal is to make the speech intelligible enough for a third person to understand. Now this can be achieved with a number of oromotor exercises targeting the lip closure, strengthening the lip muscles, working on tongue movements. Okay, so gradually achieving the tongue movements with respect to range, that is, okay, moving side to side, upward, elevation, depression, all these things, but everything is slow, okay, slow and steady. It happens over a period of time. Nothing happens overnight. So working on endurance, range, speed, and strength. for all the articulators, all the, oral muscles.
Thank you, ma'am. Now the next questions are coming in from the YouTube live stream. Mr. Sridhar is asking, what is NLP? And if a parent undergoes NLP training, will it help a child with Down syndrome?
Okay, does Mr. Hema Malini want to take this question?
Oh, actually, I didn't understand what is an NLP. I myself amused what it is.
Ma'am, I think
NLP.
neuro-linguistic programming.
Sorry, can you repeat?
Neuro-linguistic program is NLP.
NLP. Okay.
Yeah, NLP, ma'am.
Okay. Neuro-linguistic program has to be done more with the speech, I think, rather than the special education. It has something to do with the speech. Is it not?
I think
Sorry, I missed it. I missed the question because I think there is a network issue here. Can somebody repeat the question?
Yes, ma'am. The question is, what is NLP? And if a parent undergoes NLP training, will it help with a child with Down syndrome?
Neuro-linguistic and NLP.
Yes.
Okay. Yes, neuro-linguistic program is basically, it is a, what do I say? It is more of a method to sort of fine-tune your brain. Okay, it is like what do I say? It taps your psychological aspects, okay, and help you communicate better, by avoiding triggers that cause anxiety, tension, and all those things. Basically, it involves a lot of psychological theories, that forms the basis of NLP, any NLP program. It is more of a holistic sort of an approach and not a speech, language development approach as such. That's what I would say. It involves more of how you organize your brain, how do you organize your thoughts. From that perspective, they teach for overall, betterment and well-being of the child.
Yes, ma'am. Thank you, ma'am. Also, another question is, we've seen children keep food in their mouth for long, especially in children with Down syndrome. How can we help them to reduce this stuffing in their mouth?
See, basically, this is only because of weakness. Okay, so you have to look at few things. One is the lip closure. Okay, whether they are able to, as much as the lip muscles are weak, so are the muscles of swallowing. Okay, muscles of mastication. Okay, and the muscles of swallowing are also equally weak. So you have to work on these things systematically before you achieve effective and easy swallowing. You can go easy on the bolus size. Okay, and also start using different textures. Both sensory, orosensory and oromotor therapy together will make a difference, is what I feel. And it has to happen in gradation. You have to go very gradually. So if you're feeding the child one spoonful, okay, go easy on that. Reduce the quantity, change, experiment with different textures. Okay, that will sort of help you progress.
Sure. Thank you so much, ma'am. Another person has said, a child is a 3-year-old now. He's able to walk, run, and climb, but has not yet started jumping. Are there any specific exercises I should follow? I think this is directed to Sri Lakshmi, ma'am.
Yes, yes. Jumping is often a very important milestone, which is not given that an attention even from the therapist at times. So I would say yes, jumping. The issue with it is they have depth perception issues. One, and two, they have a lack of confidence in letting their body go. So jumping is a movement where our whole body has to move against gravity. It's an anti-gravity movement. So it means it's not just confidence, a lot of muscle coordination. And yes, jumping has to be initiated immediately once the child starts walking. Forward walking is completely achieved, and there is ample stability in walking. Immediately jumping has to be initiated from the therapist end, and the parents should be informed of the importance of jumping. And yes, jumping is a milestone which really needs to work on. And there are specific exercises and ways to work on with it.
Can I add, please?
Yes, ma'am.
Yeah, so when we are teaching jumping to a child, it's always better we stand behind the child rather than standing in front of the child. Usually when they're trying to train a child to jump, they hold the child's hand and then say jump, jump. But that will definitely not work. Stand behind the child, give a support at the armpits, and then say jump, jump. The child might bounce up. So this is one technique that can be used while doing a jumping. Thank you.
Thank you so much.
I'd like to add one more thing here. It's very important to understand that children or persons with Down syndrome are extremely cautious. They are so careful about everything that they do, and people don't realize it because you have to give them that time to get used to something. So anything they do, they are very careful. Like my daughter is actually visually challenged, but you will never realize it because she's so careful about where she's walking, different tiles, different areas. They normally glide through it so that you won't know that they can't see, but at the same time, they are so precautious. I want to tell you and every person that give them time. See, you are thinking of them as a person who can do everything. So why not push them? I have seen parents not wait for a child to even get to the walking stage, making them, pushing them, cannot sit, prop them up. My point is hypertonia is not just what is visible. It is also the invisible. There are so many parts of your body. I never knew that the face had so many muscles. I mean, you don't even know that your entire face is just muscles. So we never thought that they had to chew, they had to, use different types of expressions. The problem is that we are still also, you asked a very pertinent question. Now that you've asked it, why do they are so frequent bronchial infections, pulmonary infections? This is because India thinks cow's milk is a must. So after the mother's milk, normally we don't allow cow's milk because trisomy 21 and cow's milk are like being at the North and the South Pole. Please don't advocate it for children because we are seeing them getting more respiratory infections. I know my daughter had respiratory infections till she was 17. We bought a cow thinking that she would be, have more calcium with cow's milk. But then Dr. Priya has done this complete research, which is available on our website, which shows that cow's milk is detrimental to a person with Down syndrome. And please put this again and again on all your panels because cow's milk cannot be given. Also, gluten allergies, we have to check that. It's not that everybody has gluten allergies. Lactose intolerance, these are words that I used very common, but for sure, cow's milk, we can tell you.
Oh, ma'am, thank you. That's such wonderful. And I think we don't say it enough. And there are some certain things which we forget to address, when we talk about just at a therapy point of view.
You asked another question about why they take too much food into their mouth. I have a funny feeling that my daughter shoves the food into her mouth because she feels it in her mouth. I have a funny feeling that they can't express it, but their mouth has to be full for them to feel that they are actually eating. So we normally cut it into small portions and keep it. Though she's 42, we still have to take the precautions because she suffered for many years with esophagus reflux. So her swallowing is an issue. The food canal is not like ours. So everything in them, we have to analyze very slowly with the parents, find out what it is, because swallowing is a major issue with our children. They choke very easily. So parents get very scared that they're, and in India, we have this thing about giving a full bowl of food. So we try to cut it into smaller portions and say, give it more frequently, but make it in small portions so they don't throw up. I don't know, by the time we get to our parents, we will be very, very old, I think, because parental pressures are so huge. Why doesn't my daughter walk? Everybody else is walking. This comparison has to stop. I didn't want to say it initially, but I'm telling you, parents are in such a competitive world that, yes, our children will do it. They only want the parents to be relaxed. They don't want the parents to say, you're not doing it. They want to say, let's do it this way. Because whatever Bubbly did, that's my daughter, we just said, it doesn't matter, it's your style. It could be different. If I walk this way, why do you make a noise about it? If I walk slowly, wait, be patient. Patience is something that our parents have given up or lost. And I'm sorry to say this, but I tell the parents every day, wait. Waiting is your patience. And it is stressful because most people are working, I can understand. But we have a lovely team that you can approach anytime. We are at your service. If you tell us you're in somewhere in Africa, we will come. We love traveling as a team. We enjoy it more than the parents do, because it gives us a chance to be outside, enjoying the world and enjoying the parents. And we really want to do that more and more, because we have covered most of India just traveling as a team. And we have really enjoyed every bit of our parents. Thank you so much for hearing us out.
Thank you so much, ma'am. I think with the topic of your parental pressure, there's another question of, is there a psychological impact on the parent, that is the father or the mother, in terms of socialization due to the long time caretaking? And if yes, how, as a team, I think you all would have worked with how you could overcome this inhibition, this attitude that you have to overcome. They have a lot of low self-esteem.
No. I'm not agreeing with it. It's because we don't build up that social system. See, my point is, the minute Bubbly was born, we realized that we need support. It's very simple. Look outside your window. You're all living in huge communities, and it's not difficult at all if you allow them to come in. You have yourself are building up these barriers. Don't talk about everybody else not allowing it. It is because you have not opened up. Tell them about your issues. Talk about what are your restraints. How is it that I'm going to handle the child? Can you help? With caregiving is one of the biggest issues that we have, because we cannot create that community if you don't allow them indoors. Open your doors, get everybody to listen to you, talk about it, and build up the community. Take your children out much more, like into parks, into play areas. Children learn much more from outside than they do inside. If you're talking about speech, my daughter learned speech when she was in a swimming group, in a dance group, in a theater group, in art, in music. My point is, you don't restrict them. They will learn at their own pace, but they will be there. If you already have built up these inhibitions that my child might never, people don't accept, you yourself have built up that wall. So open up your own little horizons and say, I love my child. Everybody else will also love it. If you are confident, they are a confident population. The problem is this low esteem. We know how to get rid of it. Please ask them to contact us. We will start laughing and make them feel absolutely on top of the world.
That's lovely, ma'am. Now, the last question which we have for today is, a participant was wondering if there are any programs run for adults or teens with Down syndrome for their vocation.
we have about 100 programs. If they are not already on our groups, on our WhatsApp groups, we have 30 WhatsApp groups from every part of India. Please contact us. We will put you in touch with your particular state, with your particular group, and they will take you ahead. We have vocational programs. We have skilled programs. We have programs for getting them into jobs. In every field, we have been able to get them, and we have support groups for every little thing. It's also in your own languages that we can help you.
Yes, it's great to know such wonderful information, ma'am. Okay, so I think that is all the questions we could ask for today. If any more questions have to be given, need to be asked, there will be a questionnaire a survey run out, of which any questions will be, whichever questions will be asked will be answered by the panelists in a while. Okay, I will direct to Apurva for the vote of thanks.
Ma'am, anybody who wants any support anywhere, any therapist, anybody who wants any information, please contact us. Our lines are always open. We are ready to work 24/7 just to make the parent feel good about themselves. It's never about the person with Down syndrome. It's always about the parents.
I think with that, we will actually liaise with you people and send out a mail with the details on who they can contact. Whoever is registered, we can send that out to them.
Yes.
We will
Please go
be in
ahead.
touch with you. Yes,
Yeah.
Thank you. That was truly an amazing session. So I think Apurva can end the session with a vote of thanks.
Yeah, thank you, Dr. Gauri. So we all have heard the meaningful African proverb, it takes a village to raise a child. So I think as caregivers, as special educators, as physiotherapists, as speech therapists today, we've equipped ourselves with more knowledge and skill today to help families with trisomy 21. Dr. Surekha, I think you're the lighthouse. You're sharing your wisdom with so many families, and today you did that with us. We're really honored and privileged. Thank you so much. Ms. Mithila and Ms. Sri Lakshmi, I think the physiotherapy points that you put across, I think it was a great takeaway for the audience. I think it helped us to be a bit more empathetic with the parents who are having children with trisomy 21 with those specifically the physical difficulties. Ms. Hema Malini, I think like Ms. Brinda was saying, crisp and to the point, a lot of takeaways again for all our audience. Ms. Sharanya, you spoke in detail about the speech difficulties, the language difficulties, and you helped us understand how all the physical factors, how they affect the language and the oral part of it. So thank you very much to all our panelists. I would also like to take this opportunity to thank our team, Ms. Mabel, who's handled our social media, and Ms. Kritika, who's handled the tech for us today. Dr. Gauri, thank you to you as well for bringing in the medical perspective. I think we at Brainchild also are firm believers of a multidisciplinary approach. So here we are, all of us pushing each other. And I think when we all work together, our families really win. The families with children who have trisomy 21. I think it's a big win for them. So thank you one and all. Thank you to all the participants. It would not be possible without you. Thank you everyone for this wonderful evening.
When the meeting ends, there'll be a survey, just 3 questions. Please fill it out so it will give us a feedback and we can plan more sessions for all the therapists to come. Thank you, everybody.
Thank you.
So I'll be
Thank
stopping.
you.
Thank you so much.
Thank you. Bye-bye. Lovely meeting you people.
Thank you.
Thank you, ma'am. Thank you.